come on in. We want to see the talk. Hello to folks in Zoom land. We're really excited and honored to have our distinguished speaker, Dr. Katherine or Carrie Keyes, Professor of Epi at Columbia University. So folks who don't know me, my name is Adam Leventhal. I'm the director of the USC Institute for Addiction Science. And the mission of our institute is to bring together researchers, educators, and community change agents from all sorts of different fields so we can collaborate and identify new solutions to the various addiction crises we have. And part of our mission is to disseminate leading evidence. And so that's why we have our speaker series, and we're very excited to have Dr. Keyes today. So thanks for joining. So a little bit about Dr. Keyes. All right, well, I think I just want to start with, I don't want to bury the lead. I think that she is the leading mid-career, and she's not really mid-career, but I saw she got a mid-career award, and she's still young, but leading mid-career psychiatric epidemiologist in the world. So she is very well known and does amazing research that's timely, important, and I try to model some of my research questions and approaches after what Carrie does and has been doing for years. As I mentioned, she's a professor of Epi at Columbia Mailman School of Public Health. So her research is on psychiatric and substance use epidemiology across the life course, so including early and cross-generational origins of child and adult health. Also cohort effects, like historical cohort effects, on a number of different outcomes. So not just behavioral health, but also injury and suicide and overdose. She's really well known for how she approaches things with extreme methodological rigor and creative ideas to rigorously test things using real world data. And I guess more recently, and I don't know so much about this research, about using mathematical agent-based and other simulation models to inform public health and policy interventions. She's authored more than 450 peer-reviewed publications. She might be writing a paper right now. We don't know. It's a lot. It's great, though. 2 textbooks published by OUP. She's gotten a lot of different awards from a lot of different research societies, spanning Epi to alcohol. So she really cuts across a lot of different fields, millions and millions of research funding. And also a lot of service too that I didn't know about. But chair of the AA2 study section, so that's for the NIAAA Epidemiology Prevention Services, probably all those grants. So great. Maybe let's just start submitting some. Yeah, she's at the helm.
For the moment.
Chair. Right, that's right. Yeah, and also associate editor of Drug and Alcohol Dependence for many years. But I chickened out after a while. Oh, you are? All right, well, that's a lot of service. That's a big job. So anyway, let's welcome, and I messed up, but you have a new center, right?
Yes.
What's the name of the new center?
It's Social Psychiatry Implementation Social Psychiatry Innovation and Research Implementation and Training.
Okay, very cool. All right, well, much needed. So let's welcome Dr. Carrie Keyes.
Thanks so much for that very generous introduction. I hope I can live up to the lofty compliments that we're paying. So what I'm going to do today is go through one of the areas of research that I've been working on for the past 5 years, specifically around suicide clusters and trends in suicide in the United States, and how we can use methodological tools in order to understand the distribution and the causes of why suicides tend to cluster in space and time. And I think some of these methods could be really useful for people in other fields, including the addictions, as well as people who are just interested in addiction and mental health in general. And I'll start with a personal story. I'm going to be talking about suicide throughout this presentation, and I think what I've found over the years is that suicide has touched a lot of families and a lot of lives, including my own. I was just talking about my son earlier, who's now 14, but when my son was 7, his father died by suicide. And that event really obviously changed my family and also really informed my research, because this death was very preventable and really fueled my interest in really making a difference. And so I think probably everyone in this room has a family member, a friend, an experience with suicidal ideation, suicide attempts, or suicide death. And so just want to acknowledge that this really touches us all. And anyone this is a particularly sensitive period around those types of issues, feel free to log off, bow out anytime. So with that being said, I'll just start by talking about trends in suicide mortality in the US. This is recorded suicide mortality in the US back to 1900. You can see that. Maybe I can use this. Yeah, so that way people can see it here too. Okay. These are the trends in recorded suicide mortality in the US through 2019. And I say recorded because you'll see that the recorded, adjusted suicide mortality rate in the US was much higher in the early part of the 20th century than it is right now. But the recording of suicide death also differed then. So not directly comparable, but at least this is what we know based on our national statistics. And you can see that suicide deaths in kind of a modern era really were declining pretty precipitously throughout the 1990s. And then around 2000, that trend reversed. And we've been seeing increases in suicide deaths really since the year 2000. They've started to level off post-pandemic, or during the pandemic is when suicide started to level off. But the other thing I'll point out is that based on our recorded statistics, the suicide rate in 2020 is essentially the same as it was in 1900 in the US. Which is, somewhat dispiriting given the amount of suicide prevention research that we've done over that time, but we'll remain optimistic. So what I study as a psychiatric epidemiologist are environmental determinants of suicide and suicide death, and particularly around how suicides tend to cluster. And there's a famous story, some people are probably familiar with it, The Sorrows of Young Werther. This was a book published in 1774. It was a fictional story about a young man who experiences unrequited love and is so distraught that he takes his own life. And this book was incredibly popular throughout Europe, and so much so that there were increasing reports of copycat deaths. Young men who were dressed like young Werther, who were taking their own lives. There's some dispute over whether the extent to which there actually were copycat deaths, but this was a concern, so much so that the book was banned throughout several countries in Europe. And the idea of copycat suicides, or the ways in which suicide can become contagious to other people, has become known as the Werther effect. You'll see that in the literature. And the Werther effect is probably most well studied around celebrity suicides or high-profile suicide events. This is the most recent systematic review and meta-analysis of suicide reporting, high-profile suicide events, typically celebrity suicides, but there also is literature around fictional depictions of suicide, the most recent example being 13 Reasons Why here in the United States. But essentially, when you look at inappropriate media reporting of high-profile suicide deaths and changes to population rates of suicide, the meta-analyzed estimate is about 1.13. So typically you'll see about a 13% increase in population suicides when the media inappropriately reports a celebrity suicide death. We saw this in the United States. My colleagues and I found in 2018, right around that, we saw an increase in excess suicide risk around 10% after the death of the entertainer Robin Williams, who died by suicide in 2014. Shown here is the monthly suicide rate in the United States in 2010, 2011, 2012, 2013, and you can see this is the rate in the months after Robin Williams' death in 2014. And basically using a REMA modeling where we adjust for what you'd expect seasonally as well as the overall year-to-year trend, we estimate that about 1,800 excess suicides were attributable to the media's inappropriate reporting of Robin Williams' death. And that has led my colleagues and I, mostly in collaboration with the Environmental Health Sciences Department at Columbia, who study weather phenomenon, and infectious disease contagion, to really challenge ourselves to how to think about suicide as in a traditional infectious disease model. And if anyone's taken an Epi1 class, you know that in the first weeks of Epi1, you're taught to organize risk factors for infectious diseases by agent, host, and environmental factors. And we can really think about suicide in that same framework. And a lot of what we study in psychiatry and in epidemiology really revolves around host factors as risk factors for suicides. Psychiatric disorder history, previous attempts, family history, stressful life events, things like that. But you can also think about agent and environmental factors that also drive suicide death. In terms of agent factors, how exposed is someone to media reporting? Is there a firearm in the home? Those are agents by which individuals die. And there are environmental factors that we know to be risk factors for suicide, including a strong seasonal component that differs by age, temperature, altitude, and other types of factors as well. So what we spent the last 5 years doing is trying to apply this infectious disease approach to how we study suicide clusters and suicide contagion. So I'm going to go through a couple of examples of that in our work. Spatial correlations, how we study spatial correlations, how we study temporal correlations, especially through age period cohort modeling, how we're then taking that spatial and temporal correlation that we're observing in the data and trying to use that for prediction, and then going into the mathematical models that we use. We created a dynamical systems model of suicide contagion for forecasting and inference, and I'll end with some next directions that we're going in terms of the new risk factors for suicide that are on the horizon. So starting out with spatial correlations, basically, I know this looks like a mess, but you'll understand it in a few minutes. It's magical. Basically, there are many different ways that you can take a data set and try to understand the spatial correlations. What we've been doing for a long time within suicide data is using StatScan software, where we create cylindrical windows that move through time across the data set and estimate the risk of a suicide death by a geographic area. You can see that in the program. Typically, we use counties. The risk of dying by suicide in a particular county compared with what that risk would be if there's no temporal or spatial correlation. You can set the cylindrical scan window in terms of the amount of bandwidth, in terms of the amount of time, in terms of the geographic area, etc. So focusing on this upper left-hand corner right now, these are all the suicide clusters for people aged 5 to 25 in the United States from 2000 to 2020. Each of these little bars represents one cluster. That is, suicide deaths among people who are in that county were either higher or lower than what you would expect if there's no spatial and temporal clustering. So for example, taking this bar right here, there's an 11 next to it. That means that there was a cluster of 11 counties in the United States where between 2004 and 2005, death by suicide in those 11 counties was 4 times higher than what you would predict if there's no spatial and temporal correlation of suicide. So a couple things emerged from this analysis. One, you can see that the number of bars is getting more and more numerous. There's just a huge cluster of bars between 2015 and 2020, both in terms of the relative risks that are above 0 on the log scale and those that are below 0 on the log scale. So those are clusters of counties where your risk of suicide death is lower than what you would anticipate if there's no spatial and temporal correlation. But you can see they're both getting more frequent. And what that means is that there's greater inequity in where suicides are occurring in the United States. The hot clusters are getting hotter and the cold clusters are getting colder, and there's more differentiation between counties that have high and low suicide rates. And you can see that it breaks down also by different racial and ethnic groups as well, that we'll tease apart on the next slide when you actually look at the map of the US and where each of these clusters is occurring. So this combines all the data across the entire time series. But you can see that, as you would perhaps anticipate, there are suicide clusters in areas of the US that typically have high suicide rates, and that the coldest clusters really overall in the US are on the coast. But interesting findings emerged by race and ethnicity. For example, American Indian and Alaska Native populations in the US have the highest suicide rate of all racial and ethnic groups. And yet you see these really cold clusters emerge down here in kind of New Mexico, Arizona area. These are areas where there have been concentrated suicide prevention interventions. It's called the communities that, I forget what the name of it is, But there was a huge collaboration with tribal leadership throughout this period to try to reduce the youth suicide rate. And in fact, the evaluations of that program indicate that the youth suicide rate actually decreased by 25% during the course of that intervention. And then you can see it show up as a cold cluster compared to other counties that have high Native American and Alaska Native populations in them. And the other thing that you can do with these types of models is really start to break apart the trajectories of suicide, the suicide rates by county over time. So what we did in this analysis is apply a latent trajectory model, latent class model at the county level to try to see if we could identify groups of counties that not only had high suicide rates, but where the suicide rate was going up or down more rapidly than in other types of counties, and see if we can identify what the characteristics of our counties that have a high, rapidly accelerating suicide rate, or hopefully a decelerating suicide rate. So essentially what we found is that a 5-class model fit the data the best for all counties in the US, and this is from 2006 to 2020. This line down here is 17% of counties in the US that have the lowest suicide rate, and it started at 10.7 per 100,000 and ended at 13.7 per 100,000. And you can see all the way up to this top group of counties, 5% of counties in the US that have the highest suicide rates over time. And two things that, I took away from doing this analysis. One was that really these counties differentiated by their intercepts and not their slopes. Counties with high suicide rates in 2020 were counties with high suicide rates in 2006, and same for low rates. And perhaps more alarmingly, we could not identify statistically a cluster of counties in the US where the suicide rate is going down. Even in the lowest risk group of counties, the suicide rate is going up. So that's certainly alarming. Okay, so that's some of the methods that we use to try to tease apart spatial correlation over time. But another big piece of this is the temporal correlation across time, because suicide rates and suicide risk factors, even the seasonality of suicide, is very, very different for adolescents and young adults compared with older adults. And we typically do this using age period cohort models, and I'll just take you through how to interpret these types of maps. This is a hexagonal map that overlays person time for each age period cohort combination of people in the US from 2000 to 2020. So each of these hexagons represents the intersection of a certain age observed at a particular time period that were born in a particular cohort. And then within each of those age period cohort hexagons, we color the hexagon based on the suicide rate for that age period combination for that time period. And so you can see here that cohort is organized on this axis. Our oldest cohorts were born in 1919. Our youngest cohorts were born in 2009. On this axis is age. People are aging from age 6 to age 81 in our data set. And then on this axis is time. We're going from 2000 all the way through 2020. So, there's 4 panels here, one for firearm death for men, one for non-firearm, and then for women, firearm and non-firearm. So focusing on firearm deaths for men, for example, you can see a really strong age effect, right? You can see that these hexagons are getting darker and darker in color as the population is getting older and older and older. And the group with the highest risk of a firearm suicide death in the United States are men over 70 years old. But you can also see some interesting temporal clustering start to emerge. You can clearly see there's this big bulb of red that's emerging here. This is middle-aged men who are currently in their late 50s, early 60s right now, where we know, this is your classic deaths of despair cohort, where we know that that cohort has a higher suicide risk than previously born cohorts of men at that age that they're carrying with them through the life course. You can see that among men in their 50s and 60s, their suicide rates are much higher than for previous generations at that age. But you can also see that firearm suicide rates are going up even for younger men too. Down here among men in their 20s, you can see that the yellow hexagons are starting to get darker. And you can see that even more so for non-firearm suicides. So not only do you have the bulb of colors getting darker among men a little bit younger in their 40s and 50s, approaching age 60s, but you can see this major cohort effect. extending down, where now younger and younger and younger men by cohort have an increased risk of non-firearm suicide compared to cohorts of men at that age in previous generations. And you can see the similar type of pattern for women, but less marked because women have a lower risk of fatal suicide death. And when you disaggregate this by race, you see even more alarming patterns emerge. So these are data specifically among Black women that we've published that shows an alarmingly rapid acceleration of young female suicide deaths among Black women in the US. And when you look at the types and manners of suicide death, it underscores that it's really the increases we're seeing in the US are not due to firearm suicides. Especially among women, we've seen increases year over year in asphyxiation as a cause of suicide death compared to firearm. In the 2000s, women were more likely to die by a firearm suicide than another type of method, but it's really asphyxiation deaths that have increased. And even among men, especially young men, you have seen this increase in asphyxiation deaths as well. It's starting to diverge in the later years, but is not coming back to its pre-2000 levels in terms of firearms contribution to total suicide in the US. And similarly, when you break this down by race and ethnicity, you see this even more so. This is women in the United States. If you look at 1999 to 2021, less than half of Asian, Black, and white women who died by suicide used a firearm, a little over half for American Indian and Alaska Native. If you look at now the most recent period, 3/4 of American Indian and Alaska Native women who die by suicide do so by asphyxiation, not firearm. And it's well over half now for other racial ethnic groups as well. And why I think that's important to emphasize is that, rightfully so, a lot of our suicide prevention efforts are on firearm means restrictions. An increase in asphyxiation deaths is very hard to, outside of an institutionalized setting, implement means restrictions as our primary method of suicide prevention. It really suggests that what we need to be focusing on is reducing the suicidal crisis, even more so. And I'll just underscore this even more. We did a mediational age period cohort analysis where we analyzed trends in household firearm rates over time using the RAND metric for firearm ownership. And basically what we found is that the household firearm ownership rate hasn't really changed over time. That is now changing kind of post-pandemic, but over the time series that they estimated the household firearm rate really didn't change much. About 40% of households in the US owned a firearm, and yet you can see the firearm suicide rate going up and up and up. But the reason why, the reason why you see variation in suicide rates by firearm is entirely due to state-level differences in firearm ownership. So this is just overlaid, organizing the rates of household firearm rates from the state with the lowest household firearm ownership rates, New Jersey, to the state with the highest household firearm ownership rates, Montana. And this is the same, then this more jagged line is the firearm suicide rates for those states, and the correlation is 0.8. All of the variation in our data on spatial temporal correlations of firearm suicide rates are due to state-level differences. There's nothing left over after you account for state-level differences. It just does not predict the cohort effect in suicide rates. It entirely predicts state-level differences in suicide rates. So those are just some of the demographic trends and some of the ways in which we try to use statistical models to try to capture demographic trends. But what we were really interested in this project as well was moving towards prediction and forecasting. So I'll move to some of that work as well. I think prediction is a really interesting area for suicide because a lot of the work in predictive modeling for suicide has focused on clinical records, using clinical databases to try to develop prediction models for who's going to die by suicide. And they have largely been ineffective. It's very difficult to predict. Suicide is a rare event, especially fatal suicide. And it's very difficult to predict using medical records who is actually going to die by suicide versus who is at high risk for death by suicide, but who doesn't die. So we thought we could see if incorporating environmental data and environmental measures and spatial measures could improve those levels of prediction. So we created a predictive model using suicide-related deaths from vital statistics, and then at the county level, the unemployment rate, the weekly wage, the proportion of the population living in poverty, the median household income. At the state level, firearm ownership, and the proportion of the population with major depression, and then population density as well. And essentially what we found is that we can very accurately predict what counties are going to have high and low suicide rates in the US using this environmental data. So these are our covariate effect estimates for both a full and select model, where we found highly predictive associations between the variables that we put in our predictive model and the outcomes. And I just wanted to show this graph because it underscores what we saw in that paper where we detected suicide clusters among young people. This is the heterogeneity in suicide risk over time, which is a measure of the differences between high and low county suicide rates. And you can see that heterogeneity index is increasing over time, which is again a sign that there's just more differentiation in the United States between counties with high and low suicide rates. And essentially what we were able to show here are this is just for 3 years, 2017, 2018, and 2019. These are the actual county level suicide rates in the US. This is the predicted suicide rate from our model with selected covariates. And this is the error, the difference between the actual suicide rates and what we predicted. And we do really well just with this limited set of covariates in predicting county level suicide risk. We're now extending these prediction models, incorporating new sources of data. So we're partnering with Vibrant, who did run the National Suicide Prevention Lifeline, now 988. And we were able to obtain all calls to the National Suicide Prevention Lifeline for the last 10 years with geographic resolution that we can use for prediction and other types of research activities. But this is just a first analysis that we did where we created a state level, year level county call rate. So this is supposed to be a map of the United States. I've noticed when I've given this presentation that it doesn't really look like a map of the United States, but it's kind of roughly, right? Here's the Northeast, right? Here's Florida down here. This is the South. There's Texas. There's California on the side. Alaska's up here. So it's kind of rough of the United States. And each of these blocks is a state. And the black line is the state call rate ratio. This is the difference between the per capita calls to the National Suicide Prevention Lifeline compared to the national average. And the gray line is the mortality rate ratio. That is the suicide mortality rate ratio for that state in that year, again, compared to the national average. So if you take a state like California, this is kind of what you want to see, right? This is a state, your calls to the National Suicide Prevention Lifeline are higher than the national average. The suicide rates are lower, right? People in crisis, again, ecological association, but one might infer that people are calling the suicide lifeline, they're not dying by suicide. Whereas you have a lot of other states where that association is flipped. Kentucky, Tennessee, South Carolina, their suicide rates are much higher than the national average and their call rates are much lower. So you can start to infer from that, where you might want to build additional public health supports around suicide crisis and suicide lifeline, or at least interrogate why are people not calling suicide lifeline in those states. I won't go into it anymore because we've got a lot of this stuff covered. Okay, so we're building these predictive models, but really the actual goal of this project was to build dynamical models, to really try to, if we really take seriously that suicide contagion has these infectious disease properties where we could use infectious disease tools, then we wanted to build inference systems where we could forecast and predict where suicide is going to occur. And so we started to do that, kind of first principles. So just as background on what dynamical models are, we're all using dynamical models intuitively all the time to make decisions and to go about our lives. But they're process-based models that describe how system properties change through time. So you can think of something like a pendulum. You can represent the movement of a pendulum from back and forth using a dynamical model that takes into account the speed and the other properties of that pendulum. We also do this for numerical weather models. Those are all dynamical models, trying to decide whether it's going to rain tomorrow or not is a dynamical systems model where we use it to do forecasting and prediction. In traditional infectious disease models, we often use these SIR models. So if people are not familiar with basic epidemiology, but this is basically susceptible, infected, recovered, right? Like if you wanted to forecast where cholera is going to occur or COVID or any other infectious disease, you want to know who's susceptible to the infectious disease, who's infected, and who has recovered. And each of these transition probabilities is going to be dynamic. There's going to be a whole host of parameters that you can predict and infer to move from susceptible to infected and from infected to recovered. And you can use this for a whole host of activities. You can use it to understand the underlying process of disease. So for example, one question that we've been consistently asking in this project is, what is the reproductive rate of suicidal ideation in the population? Can we quantify that using a dynamical model, forecast future outcomes when the next high-profile celebrity suicide occurs that's inappropriately reported in the media? What can we expect? What groups are going to be affected? Where are they going to be most affected? These are all things that would be useful for forecasting and certainly run our collaborations with Vibrant and 988. You can also use these models for counterfactual simulation. So if I were to increase call capacity in this location at this time, with a certain number of assumptions about how call capacity impacts suicidal ideation, what is the expected counterfactual effect of that intervention in this community? So we developed this model for suicide contagion in a paper we published last year, and we focused on celebrity suicides as just a place to start because we had, for a whole range of reasons that I can get into, but we started with celebrity suicide. One of the reasons is that it's a shock, which those are somewhat easier to model than kind of long-term processes, but the idea is like we know when it happens, and we know that there's going to be shock to the population. So in that way, demonstrating it as a first principle kind of provides some nice properties. So we focused not only on the Robin Williams death that occurred in 2014, but also on 2 deaths that occurred in 2018. People will probably remember in the same week, Anthony Bourdain and Kate Spade both died by suicide in the United States. These were widely reported in the media. And we wanted to, we counted the Spade-Bourdain events as one event because of their proximity to each other, but we wanted to take 2 different celebrity suicide events in the United States and apply the same dynamical systems model to it to try to understand how the contagion processes might differ between those 2 events. We incorporated a range of data into the dynamical model. So for example, national monthly deaths all the way starting in 2003 through 2020. These are the national calls to the suicide lifeline. So this is for 2014, and you can see that when Robin Williams died, you had a huge spike in calls to the lifeline. And then this is the week that Bourdain and Spade passed away. These are our interpolated estimates of suicide deaths after removing seasonal cycles as well as long-term trends. You can see a similar spike in suicide deaths that occurred during the weeks of those suicide deaths that dissipate quickly but do not return back to baseline. So in building this model, again, this is really a hypothesis. We're positing that this is one way in which suicide could be contagious. So it's really based on theory and our knowledge of the literature, but it's not empirical. But basically, the model that we created, it hinges on a parameter that we called R, which is your average awareness of people who died by suicide. And this is a really important part of the suicide contagion infectious disease model, because we know suicide contagions are not limited to celebrity suicides. There are suicide outbreaks that happen in high schools and in local communities that are much more localized in nature. And part of the reason why we think these local suicide clusters occur is that someone who died, there's a transmission of information. And for a non-celebrity, that transmission of information is going to be much more contained in terms of who knows about the event, knows the person, has a connection to the person. It will be acute but contained for family and friends and acquaintances, and that effect is going to wane over time. And if you average across the entire population of the US, given how small people's social network are, contagion effects for localized suicide events will be small. But we posited that for a celebrity suicide, that effect could be big, right? Because it's the same process. There's still an information transfer that's going, but we're all learning about it and we're all being exposed to the same type of information, especially when there's inappropriate reporting. So you can have a much greater contagion effect for a celebrity suicide than you do for a local suicide for those reasons. So essentially we have people moving in between states, and we use the dynamical systems model to estimate these different contagious parameters using those rules. We're able to achieve a steady state solution and numerical stability for the model based on empirical data. So we can achieve very quickly a steady state of baseline suicidal ideation, just people who we know to be contemplating suicide at all times, as well as memory of the removed. So in this one, we set a shock where this is when someone dies by suicide, and you can see that memory is very acute in the acute phases of someone dying and then starts to wane thereafter. And so this is the results for the Robin-Williams model. I'll focus your attention on two different parameters that we estimated. So over here, this is our model interpolated parameters, and these are our infectious parameters. So for example, this parameter is baseline contact with the memory of death. And essentially what we show is that baseline contact with memory of death basically quadrupled in the weeks after Robin Williams died, because we were all in contact with the memory of that death, especially when it was reported in the media over and over and over again. So this is the contagion contact rate of the population currently not ideating, who are now remembering or having a memory of a person who died by suicide. And then we also have this parameter on the bottom right, the ideator contact with the memory of death. This is someone who is currently in a suicidal ideation who is now in contact with the memory of the death. So you can think about it in a similar way as someone who's now in contact with someone who's infectious. That memory itself, that information, is what we posit is the agent that's driving the contagion through the population. And you can see that that triples in the case of Robin Williams. Now, for Spade and Bourdain, you still see those same increases, but much lower magnitude. So for Spade and Bourdain, there still is contact with the memory of the death, but it only increases about 2 orders of magnitude. And then again, for the ideator contact with the memory of the death, there is an increase, but it's small. And this is consistent with the underlying data. We did not observe a similar increase. There was a small, but very limited increase in population suicide rates of death after Bourdain and Spade. We attribute that to better reporting. In the wake of the events of Bourdain and Spade, there was a real effort on the part of the suicide prevention community to educate journalists, especially after what happened with Robin Williams, to try to increase responsible reporting. And we think that had an impact, or people just didn't identify with Anthony Bourdain and Kate Spade as much as they did with Robin Williams. So that memory, that the virulence of the memory, the infectious agent, was not as potent for Bourdain and Spade as it was for Robin Williams. But, part of this is a proof of principle, because we can manipulate these 3 parameters in any way that we want to actually replicate the underlying data. So this is somewhat of a hypothesis generating type of model, because we can't actually validate the model, because any combination of these 3 parameters could recover the underlying data. Okay, so I'll just close with where we're going as a research group in terms of the impact of new risk factors. And actually, I'm not going to talk about COVID-19 because this was too long, and so I took out those slides. But anyone who wants to talk about COVID, please let me know. But I think the more pressing area that we have really been getting into as a research group is around the role of internet dissemination of these ideas in general, and particularly around pro-suicide websites and other web forums where particularly dangerous information is spread. So people might have been familiar with this story in the New York Times from 2021, where the despairing log on and learn ways to die. And it was a long story about pro-suicide websites in which over 200 deaths, actual suicide deaths, were linked to profiles that were on pro-suicide websites. And I really don't recommend exploring these. It's really, really dark and really damaging. But the publicity around pro-suicide websites itself fuels people to log in. So we published this interrupted time series analysis of that New York Times story. These are the weeks from publication of the New York Times story itself. And you can see that the week that the New York Times story was published, these are the number of Google searches for the one pro-suicide website that they actually named in the article. And Google searches for that website exploded that week. And they did go back down quickly after, but they did not achieve the pre-New York Times story article levels. We then wanted to know, especially when you think about the fact that suicide rates over the last 10 years not only have increased in the United States, but it's all these non-firearm suicide methods, which sometimes require pretty complex combinations of different types of products in order to fatally die. So we wanted to know what the association was between activity on these pro-suicide websites and the actual population rates of suicide in the US, which is very difficult information to get. The websites themselves do not share information on how many users they have or anything like that. But we are able to track over time how many people are Googling for these specific sites. So we had a range of different sites, and we just did an ecological analysis of the association between Google searches for pro-suicide websites and suicide deaths by state in the US. We use distributed lag models in order to analyze this. So I'll just orient you to the ways that this information is organized. On this axis is a relative parameter of relative searches. It doesn't really have a real-world analog in terms of its interpretation, but it's just as the number goes up, the number of searches is going up. And this is the lag in months of number of searches to suicide deaths that month, the next month, 2 months later, 3 months later. So you can create this matrix of, when this is the suffocation rate of suicide for 10 to 24-year-olds, when searches are low relatively to other kinds of things people are searching on the internet, and the lag of 0. But you can see that as searches for pro-suicide websites go up, suffocation deaths in particular really go up among young people, and poisoning deaths really go up among young people. What goes down is firearm deaths. And we were initially, and especially at a lag of 3 months, so everything circled here in black is statistically significant. But we really see the strongest signal for poisoning and suffocation deaths. And by the way, there's no significant associations total. So these two are totally canceling each other out. Overall, no association, but strong association for poisoning and suffocation, strong negative association for firearms. And we were really curious about this, so we talked to the reporters of the New York Times article, as well as other people who are really familiar with the pro-suicide websites. And what we think, and we don't know, this could be total noise, these are ecological associations, it's Google searches. Obviously many people are accessing these sites without Google searching first. So messy, but hypothesis generating perhaps. But what is true is that firearm deaths are really discouraged on pro-suicide websites because the probability of long-term disability if you survive a firearm suicide attempt is quite high. So your quality of life is lower. So really what's advocated is asphyxiation and poisoning deaths. So we don't know whether this is, real trends that we're seeing, but it's certainly consistent with what people know about how people are discussing suicide on these websites. And we see the same kind of trend in the associations for adults. I should have pointed this out. Yeah, I did. This is 10 to 24-year-olds, where you see the strongest signals, strongest associations, also the highest number of internet users, also the highest number of people in suicidal crisis who use the internet to gain information, 10 to 24-year-olds. But if you look among an older age group, you see similar associations, especially for poisoning, which is the number one method that people talk about on pro-suicide websites, and especially among women, which is the more significant users of the internet to find out information about suicide. So again, totally ecological associations, but we really think that this is an area that we want to delve into in terms of kind of combining this expertise in suicide contagion and messaging with this new risk factor, which is how people are disseminating information online. I mean, just a few weeks ago, there was a celebrity suicide spouse, and the major who died by suicide, and the major gossip sites had to shut down their comment section because of all the inappropriate discussion that was happening there. So this is something that is a new risk factor. As a public health community, we don't have good tools in terms of suicide prevention. So really understanding the force of infection and how it differs when this information is spread online, we think is a really important area for next steps in this research. So to conclude, suicide continues to be a national health crisis. Even though suicide has leveled off in the last few years, especially since the onset of COVID-19, it's still orders of magnitude higher than it was 25 years ago. We think that the spatial and temporal correlation of suicide is really important to understand the distribution of how these deaths are occurring across the United States, and that typical clinical risk factors or host factors alone are not sufficient to understand why these distributions are occurring in such unequal ways across the US, and it's not just driven by firearm access. The increases in suicide are occurring predominantly among the non-firearm methods. We think disparities are a key consideration moving forward, especially these troubling trends we're seeing in particular among young Black women, but also other racial ethnic groups as well. And we just need better data. You know, we're using Google data essentially because it takes years for other types of surveillance data to come out. And so we're trying to use the best information we can. We get the 988 data with a 1-month time lag, and now we're exploring other types of AI methods to, kind of get internet information that's beyond Google searches. So we're hoping to use all of this to develop novel methods for forecasting and surveillance so that we continue to really try to understand what's going on in suicide in the US. So I'll just end with a story. I started out talking about the sorrows of young Werther, a young man who experiences unrequited love and takes his own life, and was kind of thought of as the start of this copycat suicide phenomenon. But then there's also this effect that we talk about in suicide prevention, the Papageno effect. And so people probably are familiar with the Magic Flute, the opera, Mozart. Okay, it's all right. But in the opera, there's a character, Papageno, and he also experiences unrequited love. And in Act 2 of the opera, I think it's Act 2, Papageno also decides to take his own life. But what's different is that in the Magic Flute, the community comes out and they sing to Papageno and they tell him that he's a valued member of the community and that he really has a place in this world and that the community loves and respects him. And Papageno doesn't die. And so we talk about Papageno effects in suicide prevention as kind of the counter to the Werther effect, that we as a public health community and just as community members around your friends and family have a role in suicide prevention. And helping people see that they have a place in the world and that they're loved and valued is really something that's critical from a population-wide standpoint in order to reduce suicide deaths. So I would just conclude by thanking my co-PI on this project, Jeff Sheeman, who's an amazing infectious disease modeler, and all of the colleagues who helped us along the way as well. Thank you.
Questions from the crowd? And Vicky's on her monitoring if there's any chat questions.
Yeah.
Thank you so much for the talk. It's so interesting and a really important topic. My question is about the contagion contact rate in response to this celebrity suicide deaths. I was wondering if those rates have been modeled for other countries and if we could maybe use that to sort of make conclusions about differences in media reporting and how that vary by country.
Yeah. I mean, the Robin Williams event is quite unique in that a similar increase in suicide deaths after the Williams event was reported in Australia and in Canada, and I think at this point in several other countries as well, but mostly English-speaking countries, but in large part. And we attribute that to internet reporting. It used to be that media reporting of a celebrity suicide was relatively local, at least national. But now, Robin Williams was a beloved entertainer in many different countries. It's not like the media reporting stops at the Canadian border. And so similarly, you saw those increases for those other countries as well. Typically, for other kinds of celebrity suicide deaths, they are more local in terms of the country that's most affected. But I think that's really going to change. And I think Robin Williams is one example of that. For example, K-pop stars. There was a K-pop star who died by suicide a couple years ago, and we saw increases in youth suicide deaths well beyond the countries where K-pop is most popular traditionally. So things like that, like the world's just becoming more global, and the internet is globalizing everything. So we're not going to see the same types of localized effects for those contagions, which is why I think we really need to harness this internet information to try to understand virality in a different way.
Can you talk a little bit more? What do you mean by inappropriate reporting?
So the WHO has guidelines, and a number of other medical administrative bodies have guidelines about media reporting. But typically, what we ask of the media is to, not talk about the means of suicide for someone who died, not talk about it as a solution to a problem, not talk about them being in a better place, using that type of language. They had a mental illness and now they're at peace. That type of language is very triggering. And I don't know if people remember when Robin Williams died, but the media reporting was egregious. The sheriff of the county where he died did a live news conference from the room where he died and showed on CNN the tool that was used. I mean, it was so far beyond anything that I've seen in terms of inappropriate reporting that it was really egregious, and it went on for days and days and days. I don't know if people remember this too, but it was very much discussed as a solution to a problem. He had a chronic illness, and so it was very much discussed of this is someone who was suffering and is at peace now. Which I understand that sentiment that can be seen as very soothing, but you have to imagine yourself in a suicidal crisis and you say, this guy's, he's at peace. And if we look at the demographics who died by suicide, the excess suicides after the Williams death that we estimate from the ARIMA models, it was men in the same age group, same demographics. Anyway, so that's kind of but there are really great, Kurt Cobain's death is often used as an example of really good media reporting on a celebrity suicide. I mean, talk about someone who's a beloved figure. MTV had the National Suicide Lifeline playing at all times whenever they reported on Kurt Cobain's death. Courtney Love's speech is cited frequently as, again, this isn't quantitative, but is cited frequently as one of the reasons suicide rates did not increase, which they didn't among youth after Cobain's death. She came out, there was a vigil, like a huge vigil in Seattle, a couple days after Kurt Cobain died, and she just laid into him. And I was like, this is not a solution. Like, this devastated my family. Really talked about it in very stark terms. And people were angry at Courtney Love about that, but, that's good reporting. It's not a celebrity suicide. So that's the type of stuff that we talk about.
I just have a quick one related to that. I was thinking of that one because I remember she read the note. And
Yeah.
I'm wondering if you've seen any effect for notes from people, because it kind of gives you, I guess, the person's reason. And a lot of times it's just like, why did this person do that? That one was very clear.
Mm-hmm.
I wonder if there's anything that you've seen related to how notes impact.
No, Rory O'Connor is a suicide prevention researcher who analyzes suicide notes and has written a lot about the effect of suicide notes. I don't know about celebrity suicide notes, but in general, when you think about the language of suicide notes, it's often, this is where we get the whole idea of burdensomeness, which is a big idea in suicidal crisis, that most often the reason that people move from suicidal crisis to death is that they feel they are a burden to others. And you see that very frequently in suicide notes. But kind of beyond that, I'm not really sure if reading a suicide note is bad or good, or I'm not sure.
Question online related to that. It's when someone dies, for example, Matthew Perry viewed drowning after being on K and does not leave a suicide note. What is the likelihood of error of distinguishing suicide from accidental deaths?
Yeah, that is a big question in the suicide literature, especially around drug overdose, that you don't know. Suicides in the United States are designated as suicides by a coroner or a medical examiner. And the methods to designate a suicide differ quite a bit by county. And in many counties, they won't designate a suicide death unless there's a note. In other counties, they do a lot more forensic investigation. So when you have a drug overdose, for example, and you're not really sure of the intentionality, oftentimes those will be designated as an unintentional death. And poisoning, suicide by poisoning, is quite low as a method of fatal suicide death. And we think that part of that is because there's a lot of deaths that are designated as unintentional overdoses that may have been suicides. But put yourself in the shoes of a coroner or a medical examiner, and it's really difficult to make those decisions oftentimes.
I have a couple more online. Okay. Do you count such organizations as the Hemlock Society as a pro-suicide website? And do you have thoughts on medically assisted suicide?
Yes. Those are great questions. Things like the Hemlock Society and medically assisted suicide, certainly I think that people agree that there are circumstances when it is humane to allow someone to end their own life. But I don't know if people are aware, for example, of changes in laws around medically assisted suicide, particularly in Canada, where medically assisted suicide has gone up exponentially. And there's a lot of ethical questions around the role of psychiatric, allowing someone with a psychiatric disorder to consent to a medically assisted suicide. These are quite contentious areas. So I guess my opinion is that certainly there are obvious examples where allowing someone to take their own life is a humane and responsible thing to do as a society. However, I will say that implementing laws around medically assisted suicide have had a lot of unintended consequences that I think potentially impact population rates of suicide in ways that we don't want.
And one more line.
I have a question. So I'm thinking back to those panels where you're kind of looking at different cohorts across different times, across different ages, and there's little blips of increase in suicides, non-firearm suicides among younger populations. So thinking about that and thinking about what you said about news going online, and I'm also thinking about here checking these celebrity suicides. Are there other environmental factors that you might want to look at, or that might be interesting as we see this shift?
Mm-hmm.
In which case there might be trends.
Mm-hmm. Yeah, those are really good questions. There's a lot of other environmental factors that people have posited to be driving increased rates of suicide. I think particularly around economic factors and wage stagnation and erosion of the middle class and kind of, sort of the more deaths of despair type of mechanisms that are particularly affecting young people. Obviously, kind of the spillover of the drug overdose epidemic that tends to claim the lives of young people and leaves in their wake people who are, in crisis in a number of ways, even if they themselves don't die of drug overdose. So all of those things are going on simultaneously. And I think all are probably contributing in some way or another.
I have one question just about, I was thinking a lot about overdose hotspots and other types of hotspots for new drugs that come on the market. To what extent are you seeing crossover of the methods that you're using? You got the cylinder. You're talking about that?
Mm-hmm. The cylindrical scanner.
Yeah. Is there
I've seen
making sure that addiction science is kind of using some of the latest and greatest of what you're doing and psychiatric epi and suicide?
I've seen it more at a city level. When people really want to understand what corners or what particular areas within a city, because I think at a national level, probably.
Yeah.
I don't know that it would be that informative because it, be Appalachia, big cluster. You know what I mean? Like, I'm not sure that it would be as informative in kind of detecting those local areas, but I've seen people use these types of metrics at a city level, and I think it's very valuable there.
Do you mind doing one more?
Sure.
I see that unemployment sampling field is gathered in predictive modeling. Have you ever sampled occupations specifically interested in correction staffing?
I haven't looked at correction staffing, but actually I'll point people to, where was it? No, it's up here. This paper. We actually looked at labor market activity and characteristics as predictors of trajectory membership. Using similar, there's a whole, was developed for drug overdose, a whole set of factor analyses around labor market characteristics, whether you're in a county that has high agricultural, like agriculture is driving a lot of the jobs versus service is driving a lot of jobs versus professionals are driving a lot of jobs. And there are certainly associations with particular counties that have particular industries and which class they're in of this overall suicide rate. I'm like pointing at this like you can see it. And which class they're in terms of this overall suicide rate. So that's one area we've been looking into, but we didn't really examine it in a time varying way, which I would like to do because I think it would be important to know, like, as job characteristics and labor characteristics of county changes, then what happens to the trajectory of their suicide rates. So this was more of a descriptive risk factor analysis.
Thank you again, Dr. Hughes.
Oh, there's a question. Yeah.
Yes, during the pandemic era, suicide rate will increase.
During the pandemic, the suicide rate did not increase, and for young people, it decreased during times in which schools were closed. School attendance is a risk factor for suicide among youth, and so, during the summer of 2020, or during the time periods in which school closures occurred across the United States, is the first time in like the last 20 years where the youth suicide rate was at its summer rate, which is lowest for kids, is in the summer. For adults, largely suicide also kind of stabilized and declined in a lot of places in the US throughout the course of the pandemic, which certainly was unexpected. And there are a lot of theories as to why that is. Personally, for adults, I think we had the largest expansion of government benefits to stabilize incomes and reduce eviction in the United States in like 100 years. And I think that that was an effective suicide prevention intervention. But other people disagree.